Hello and welcome to this Friday weekly webinar. Today to talk about lean diabetes mellitus, an unexplored emerging entity, we have with us Dr. Sandip Mukherjee sir, who is Associate Professor, Department of Physiology, Serampore College, West Bengal. आपका बहुत बहुत स्वागत है सर.
Thank you, ma'am. Thank you, sir.
We also have Director of Mukherjee Desai National Institute of Yoga, Dr. Ishwar V. Basavaraddi sir with us. आपका भी बहुत बहुत स्वागत है सर. We also have Communication and Documentation Officer of MDNIY, Mohammad Tayyab Alam sir with us. आपका भी बहुत बहुत स्वागत है सर.
Thank you, Dr. Vandana.
हमारे संस्थान की परंपरा के अनुसार अब कार्यक्रम की शुरुआत प्रार्थना के साथ करते हैं. सहना भवतु सहनो भुनक्तु सह वीर्यं करवावहै तेजस्विनावधीतमस्तु मा विद्विषावहै. ओम शांति शांति शांति. ये हमारे लिए सौभाग्य का विषय है कि डॉक्टर संदीप मुखर्जी सर, जो कि डिपार्टमेंट ऑफ फिजियोलॉजी श्रीरामपुर कॉलेज वेस्ट प्रोफेसर के पद पर कार्यरत हैं, आज हमारे बीच मौजूद हैं. लीन डायबिटिस मेलिटस एंड अनएक्सप्लोर्ड इमर्जिंग एंटिटी विषय पर बात करने के लिए आपका एक बार मैं पुनः स्वागत करती हूं सर. इसके साथ ही साथ हमारे संस्थान के वरिष्ठ अधिकारीगण, हमारे संस्थान के निदेशक महोदय जी तथा संस्थान के संचार एवं प्रलेखन अधिकारी, आप दोनों का भी मैं पुनः हार्दिक स्वागत करती हूँ. इसके साथ ही अब मैं संस्थान के संचार एवं प्रलेखन अधिकारी मोहम्मद तैयब आलम जी से अनुरोध करूंगी कि कृपया हमारे आज के अतिथि वक्ता का परिचय प्रस्तुत करें. सर.
Thank you, Dr. Vandana. There are some issues with the video. Good evening, everyone. Respected Dr. Sandip Mukherjee sir is Associate Professor in Physiology at Serampore College, University of Kolkata. Mukherjee sir has been working on islet cell biology, diabetes mellitus and nutritional intervention since 2002, and awarded with different research projects funded by UGC, ICMR, and DBT Government of India. Dr. Sandip sir has published more than 60 research articles in national and international journals of well-repute. He is also the author of 4 books and published 2 books chapter with national and international publisher. Dr. Mukherjee sir is also registered PhD supervisor in physiology under University of Kolkata since 2012. Sir is an editorial board member of hepatology and pancreatic science and reviewer of different international journals published by Elsevier, Spring Nature, Willig, Taylor, and so many others. He has received Serampore Host Research Award and a fellowship from DST, Government of West Bengal, and National Tea Research Foundation, Government of India. Dr. Mukherjee sir is a member of different scientific societies like Indian Science Congress Association, Physiological Society of India, Indian Association of Biomedical Scientists, and Society of Biological Chemists. With these few words, we thank you, sir, for accepting our invitation for Friday webinar, which is quite popular in different social media platforms, and we have also the audience both from national and international viewers. Now I request respected Dr. Ishwar V. Basavaraddi sir, Director Mukherjee Desai Institute of Yoga, to say a few words about today's topic. Sir.
Om Shanti Shanti. Today's esteemed speaker, Dr. Sandip Mukherjee ji, Associate Professor of Physiology at Serampore College, University of Kolkata. a very well-known institute. And my colleagues in the institute, Dr. Sri Vandana, faculty members Rameshwar, and others, student friends and yoga enthusiasts joining this webinar through various social media platforms. It's our proud privilege. Today we have a very thorough researcher. He has done a lot of outstanding research in his field area of specialization. And the topic is very interesting: lean diabetes mellitus and an unexplored emergency entity. It's a very talk. I've gone through the extract. It's very interesting because consequences of obesity-induced type 2 diabetes mellitus. It's called T2D. Is well known, and many alternative therapists are also working on it. Not only modern medical scientists like yoga, naturopathy, Ayurveda. Traditional medicines are also working on the many consequences related to T2D. So there, many people miss the scientific line. Especially many people advise the diet, exercise, breathing, relaxation, so many things, even the medication. But in my opinion, we need a evidence-based protocols, diet patterns, because as per my experience, particularly diet cannot be standardized. It is depends upon the area to area, place to place. The habituary changes, diet habits are changed. Bengal is different, Goa it is different, Assam is different. If you go to the hill station in Uttarakhand, it is different. So we cannot, but I also don't recommend a calorie-based diet. It's a wholesome diet because diet plays an important role in the mental well-being. So if you are not satisfied with the food, that also causes the mental agony, which is suppressed. As a yoga person, I'm telling. So anything you are having the desire. So desire, if it is suppressed, it becomes a matter of some. It will be explored in some other physiological condition like TD. Therefore, where the scientific evidences, I said the regional priorities of the diet, and then comes to the even the exercise physiology. It's not the same from different parts of the country. In India, I'm talking only about India, not about the world. So there also we have to change. Suppose I found the pranayama, what we practice in the south is different. The pranayama practiced, being practiced in the north or in the hill station. Suppose in the high altitude area, the pranayama practices, the ratios and etc. are to be modified according to the climatic conditions. So that's why this is a very diversified field, and most important is T2D is a very the consequences of T2 are very expensive also, and it affects our well-being, day-to-day well-being. So most of the time, yes, we have diabetic, we have hypertension. Many people have, but at the same time, living with diabetes, living with hypertension, managing them without affecting our mental well-being, enjoying the life. Life is always to be happy and pleasurable. So that is our main intention, because health conditions are not the same from childhood to the old age or to the death. They are go on variety. We cannot avoid in the present circumstances who are working under the many stressful conditions, pollutions, etc. These are all now we have accept the realities, but at the same time, what the science says, what the traditional medicine says, how we can have a path so that we can live well. With these few words, I just spoke general words, but Dr. Sandip will definitely put it in a very scientific manner, systematic manner, so that we will be enlightening. So with these introductory opening remarks, I once again welcome Dr. Sandip and my colleagues to this webinar. Now I request Dr. Sandip to give a talk on the topic lean diabetes mellitus and an explored emergency entity. Dr. Sandip.
Thank you, sir, for kind introductory words, which are very relevant. And I'm just here to start. Where just use end with your talk. Diabetes mellitus is now a presence in the society. Everyone is just that is an unavoidable condition, to avoid this kind of stressful condition or like that. So thank you, sir, for your kind words, and thank you for giving me opportunity to present this talk in your this esteemed webinar organized by your institute. And also, I thankful to Dr. Bandana Singh and Dr. Ramesh Pal for considering me as a speaker in this webinar. So let's start with this topic, lean diabetes mellitus, an unexplored emerging entity. I'm from Serampore College, and it's an historical college in India also, because already we covered 200 years of journey in 2018. This is our historic building of Serampore College. So I welcome you all if you visit anytime, if you have that kind of chance to visit our college in future. So let's start with some kinds of statistics, because where we just now stands as directors are rightly pointed out, that it is almost inevitable for the individuals to escape from this kind of metabolic syndrome, particularly the diabetes and the obesity and everything. And as we in our daily life, there are so much of a stressful condition, different kinds of dietary behavior. The most important is the heterogeneity among the dietary factors, dietary behavior in the different ethnic population. So currently in 2021, as per the International Diabetic Federation, there are almost 537 million diabetic population, and they predicted that almost nearer to 40%, they are totally unaware about the diagnosis of the diabetes or the occurrence of the diabetes. That is one of the important features of the IDF Atlas 2021, where a huge population who are particularly unaware about the occurrence of the diabetes, and it is predicted to reach almost 784 million in 2045. Based on some kinds of criteria, but if we just follow some kinds of this prediction, the original scenario may be different, which will be discussed in next slides. You can find some different kind of data. And if you find the change or the prediction in the increment in the diabetic population all over the world, some regional specific data here, where North American, Caribbean may predicted for the 24% increase, wherever Europe only 13% increase, and Western specific almost 27% increase. But when you get the other side, like South and Central America, there is 50% increase in Africa. From 24 million, although the right now that we in 2021 only 24 million are there, and may also be some kinds of unaware people who are not diagnosed yet with the diabetes, but they have some kinds of diabetes. But it is predicted to increase up to 55 million, that is 134% increase increase in the African region, and also in the Middle East and North Africa. There are almost 87% increase, that's the predicted score. And in Southeast Asia, where we actually residing, there is a increase in the 68%. So these kind of statistics, if you just compare with some kinds of the BMI across the world, like according to the BMI, you just classify whether some individual are obese or lean or whatever. Although this kind of classification is not so much validated in terms of the classification of the diabetes, but if we just in a crude way classified that obese or non-obese diabetes, so according to the BMI data, you can find this African region where the predicted score is higher, much higher, even in the Middle East and the Southeast Asia, where the BMI score is almost in the lower half. You can find here from 20 to 23 or 24. In most of these areas covered by this kind of color codes that having the 20 to 24% BMI. So you can compare, you can associate the predicted score in the diabetic population for 2045 from 2021. That almost very much well in line with the BMI, already reported BMI from the different region of this kind of African countries or of the Southeast Asia or the Middle East. So there are some kinds of clue from this data that there are some proportional increase in the specific diabetic population who are not covering the conventional idea of having the adiposity or the obesity. So if you find the data from that European countries or the other North American countries where the proportion of this kind of obesity or adiposity are much higher. And also there is a different classification for the obesity or to define the obesity. So this kind of data from this all over the world with in the perspective of BMI, we can make some kinds of idea that the surge in diabetic population for the next 20-25 years are almost conglomerating this kind of this region of the world where the BMI level almost in normal range or below the normal range, like even some parts of the different parts of this region having the BMI range of below 18 or 20. So this kind of data hypothetically they support the occurrence or the surge of such number of diabetic population in this part of the region or in this region of the world. And if you point out some facts or highlighted some facts from the diabetic atlas of 2021, that almost 94% increase in the number of people with diabetes by 2045 will occur in only restricted to the low and middle income countries where population growth is expected to greater. And also this pandemic makes some kinds of change in magnification of the surging of this kind of number of population by increasing in day by day with the diabetic population of they are diagnosing with the diabetes. And also the number of people with diabetes in the IDF Africa region is expected to increase, as I mentioned in the statistical data, where 134 there is 129 to 134, there is a range, the highest predicted increase in all the regions. And if you consider the Southeast Asia, that 1 in 4 live births in Southeast Asia are affected by the hyperglycemia during pregnancy. That is the gestational diabetes mellitus. So for this kind of non-obese diabetes, this is one of the important predictor, that is the gestational diabetes and the birth weight, which will be discussed later. So we can communicate with the facts that was covered by the International Diabetic Federation in their latest report. This kind of data, which actually converging in such a conclusion that some kinds of change in the scenario, some kinds of change in the platform for the different predictors which are generally considered for the type 2 diabetes. But this data is actually pointing out to some different facts and also some different epidemiologic study are there, even different reports are there, which are also well in line with this kind of facts as published by the 2021 Atlas, that the prevalence of non-obese diabetic among the different population are increasing very alarmingly. And which needs some kinds of concern, because in the different reports or the different epidemiologic data, they are pointing out to the fact that the basically pathophysiology of the lean diabetes somewhere is different from the conventional type 2 diabetes, and there are some different factors or different aspects of this kind of non-obese diabetes or the lean diabetes which needs some kinds of exploration exploration in terms of the pathophysiology, exploration in terms of their treatment schedule, exploration in terms of the different physiological phenomena which are associated with basically this kind of non-obese diabetes or the lean diabetes. As I mentioned, that is the, if we consider or we just throw back with the different predicted score previously, you can find this kind of predicted score are there from 2021 when we reach almost 537 population. But this curve is very important, because if you find the data of the different data, like 333 million people as predicted by the IDF during 2003 to be reach or to reach this kind of population. And if you consider this kind of 230 data, like in 2021, it is predicted that 643 million diabetic population will be there in 2030. But when there is some kinds of prediction done during the 2019, that is just only 438, and during 2011 that was predicted to be 552, and in 2019 that was predicted to be 578, but in 2021 that is predicted. So whatever the predicted score, because this predicted score in the 2021, that 783 million that will be reached in 2045, we can expect in near future, when the next IDF Atlas will be published or next IDF report will be there, that may surplus, there will be huge surplus in this population, because there are so many factors which are basically which are responsible for this kind of change in the predicted data, and day by day we are exposing to different kind of factors, different kind of condition, different kind of dietary habits, different kind of stressful condition. That's why there is a huge change in the predicted score when we consider the previous years, like 2003 or 2006 or 2011 or whatever. So we can expect the huge surplus or huge surge from this predicted score of 783 million. So this is a very important fact, because as we are going through some kinds of pandemic, which needs to be taken into consideration, because previously we hypothesized that COVID-19 trigger some kinds of global diabetes burden in 2020 during maybe during the May or June. But after that, we are getting different kind of reports from the different corner of the world, that the number of individual they are registering their name in the diabetic registry in the different population, in the different study, or even in the different health data from the different country, that are pointing out to the fact that this COVID-19 may be considered as a great initiator in surging or in making that kind of surge from 783 million to a huge surplus. So we need to consider in this kind of condition, this kind of pandemics, or we don't know how much this will actually contribute in the total diabetic burden day by day. So we can expect some kinds of huge surplus in the total number of predicted population in 2030 or even 2040 or even 2045. But as I mentioned, that scientists all over the world, they extended their great effort and also did a great line of research to characterize the pathophysiology, characterize the condition, the physiology and pathophysiology, the clinical conditions, and also the different physiological phenomena associated with the type 2 diabetes, mostly, and its association with the epidemic of obesity. Very little is known, because if we consider the non-obese population, or non-obese diabetics in the current scenario all over the world, as per the IDF 2021 Atlas, that is, there is an increase from 4% in the earlier diabetic atlas in 2019 into almost 10 to 14%. There is also a huge surge. If you consider the data of 2019, the non-obese population or the non-obese diabetics are only 4 to 5% among the all diabetics. But if you consider the 2021 data of the IDF, there is a huge surge from 4% to almost 10 to 14% in the different region, and the maximum surplus are covering this region, like the Africa and the India, the Bangladesh, Pakistan, Middle East, and the other countries, where there is a continuous changing economic transformation are going there, or the occurring there. And the most of the population, they have such kind of sarcopenic obesity that will be discussed. I will discuss later what is actually sarcopenic obesity. So the population of the sarcopenic obesity is much higher in this region. So so this kind of particular entity of lean diabetic mellitus, or lean diabetes, or because when this kind of lean diabetes, the term actually coined very previously, almost it is on 1981, and after that there are so much of different kinds of different format of this kind of diabetes in the obese population have been reported and have been discussed in the different research, in the different articles, like malnutrition associated diabetes mellitus, like non-obese diabetes mellitus, J-type or Z-type diabetes mellitus, or some kinds of Jamaican diabetes mellitus. But all these terms are ultimately conglomerating into a specific criteria, that this population are basically they have either normal BMI, or they have the lower BMI, like they're malnutrited. So these are almost related with some kinds of malnutrition or some kinds of sarcopenic obesity. So and different reports, like although they are very limited regarding the detailing or the regarding the exploration of the different predictors or the causative factor, plausible explanation for the different pathophysiological aspect of the lean diabetes, or a different kind of physiological parameters in the lean diabetic population, and also their particularly their in respect of the treatment schedule, how the drug prescription will be specific for the lean diabetes. Different reports actually pointing out to the fact that they have some kinds of a different entity in terms of this pathophysiology, in terms of these predictors or the possible causes, and also in their progression of the diabetes from pre-diabetes to onset, and then to the progression of the diabetes is quite different from the conventional type 2 diabetes or some diabetic population in the obese diabetic population. So that's why this population, this particular population, the lean diabetic population, needs some kinds of concern, needs some kinds of exploration to find out the exact mechanism or to exact pathophysiology of the this lean diabetes, and by which we can make some kinds of treatment schedule or the intervention schedule, either by some dietary factors or some lifestyle changes or some kinds of drug, some kinds of physical activity, or whatever the available option are there for the intervention of the diabetes mellitus. They need some kinds of different kind of intervention pattern, or some kinds of intervention status to treat this kind of lean diabetes. That's why they need some kinds of expression of the mechanism of the lean diabetes. if we consider the clinical features of the lean diabetes, there are some kinds of totally different heterogenic factors of the heterogeneous entity prevailing in the lean diabetic population. As I mentioned, that mostly these lean diabetic population, they are low or normal body mass index, no low or normal BMI. Although I have mentioned here 18 to 25, because among that 10 to 14% the lean diabetic patient among the total diabetics, most of the individuals are included in this category, that is 18 to 25. That's why I mostly that is the most susceptible BMI group, or most important BMI, or the most important range of the BMI, where mostly these kind of lean diabetic population, that means the reported lean diabetic population, they are within this kind of BMI range, that is 18 to 25. And for antibodies, if you consider the antibodies, they almost the different GAD or IA or some kinds of other IP3 antibodies or IC antibodies, which are very specific for the diabetes mellitus, particularly the type 1 diabetes mellitus, those are absent. So it is not considering as a type 1 entity, because as it is considered as a type 2 entity, but some pathophysiological condition may indicate its inclusion as a type 1. But if we exploring the or if we find out the antibodies present in the different population of these lean diabetics, they are almost very low, almost that is 4 to 5%. And also this kind of antibodies percentage is very much less as compared to their obese counterpart. Also, if we consider just the non-obese diabetics with the obese diabetics, then we can found the antibody proportion, which is almost limited to 4% to 8% among the lean diabetes, and it is almost 16 to 20% in the type 2 diabetes. So the antibodies also kind different antibodies titer, also kind different scenario in the lean diabetic population as compared to their obese counterpart. And family history of diabetes is around 50%. Insulin sensitivity, it is one of the important factor or the important aspect of this kind of lean diabetic population, that they have higher proportion of insulin sensitivity. So we can nullify to some extent regarding the insulin resistance, that is the conventional format of the type 2 diabetes, that is the insulin resistance. But the lean diabetic population, they have a much higher prevalence of insulin sensitivity. Some study reported it is between almost 48 to 55%, but one cohort study from the Chicago group, they reported that it is almost more than 78% lean diabetic population, and they are very much insulin sensitive. So it is quite different from the obese type 2 diabetes, because obese type 2 diabetes, there is a joint venture of the insulin resistance and the insulin islet cell damage or the islet cell dysfunction. But the lean diabetes, they are almost highly sensitive, because that, as I mentioned, that some studies they reported the insulin sensitivity pattern or the range of insulin sensitivity is almost 78%, and some other studies they reported it is in between 45 to 55%. And insulin dependent and diagnosis, it is also it is also another important part, that is the 35% they are insulin dependent. As I mentioned, that sometimes some factor, some pathophysiological condition may indicate the inclusion of this lean diabetic population among the type 1 diabetes, but they have some other clear-cut criteria, some other clear-cut pathophysiological conditions which prevailing in the lean diabetic population, so make them some kinds of other entity that also from the type 1 and also from the type 2 counterpart of the obese population. So in the lean diabetic population, 35% individuals they need some kinds of insulin therapy or insulin, they are insulin dependent. So this indicates some other side of the pathophysiological mechanism where they are highly insulin sensitive, but another side, they need insulin for their intervention study or the for their intervention or the therapy, because there is a severe reported islet cell dysfunction in this population, and these kind of criteria make them separate entity from the classical type 2 diabetes or the obese counterpart. And also the risk of ketoacidosis, this is very low. So as we know, that diabetic ketoacidosis is one of the important metabolic criteria for the type 2 diabetes, or the important metabolic pathophysiological condition of the type 2 diabetic. That is also some other population, they are very much low as compared to diabetic population. So these are the criteria. These are the specific aspect or the criteria prevailing in the lean diabetic population, which makes them a separate entity. And because of this kind of pathophysiological condition present in the this lean diabetic mellitus population or the lean diabetics, they need some kinds of different intervention schedule, or some kinds of different lifestyle changes of the dietary factors. And also, if we look through the different predictors, the most important predictors is the prevalence of smoking, alcoholism, and the pancreatitis. These are very much higher, the prevalence rate of these kind of factors, like the smoker population, alcoholic population, and having the pancreatitis. That percentage is very higher, and it is almost reported from the across the different reported study. It is almost more than 55 to 60%. So that's why these kind of factors, they needs to be in consideration when we discuss the pathophysiology of the lean diabetes mellitus. So here I just pointed out some specific pathophysiology, because in the different studies they have mentioned different kind of criteria, different kind of aspect, because as I mentioned initially, that there are very limited number of study which actually make some kinds of in-depth exploration about the pathophysiology of the lean diabetics. So whatever the study available, those are mostly the cross-sectional study or some kinds of epidemiologic study, but some mechanistic study, they are very scarce, or they are very limited in considering the particular lean diabetes mellitus. So the major pathophysiologies are included the rapid beta cell failure as opposed to the insulin resistance. As I mentioned, that these population are highly sensitive to insulin insensitivity, and they have almost normal insulin sensitivity as compared to the obese population, but they need insulin very early stage of the diagnosis, because they have uh, severe beta cell dysfunction or severe perturbation in the functional aspect of the beta cell. Because some studies, they pointed out that beta cell failure is actually a outcome of the functional dysfunction, or the dysfunctional beta cell, or they don't have that kind of structural dysfunction, but they have some functional dysfunction. So there may be some kinds of condition, or there may be some kinds of points or characteristics of the beta cell which needs to be explored, how these kind of functional discrepancies or the functional perturbation may be corrected with some kinds of therapeutic intervention. So this is one important aspect or important pocket of this lean diabetic population. They mostly they need some kinds of focus on this kind of amelioration or the correction of this beta cell function, because different study also some reports are there from different parts of the world, that the total islet cell volume, particularly the beta cell volume, are not significantly different from the obese population. So, so that's why that the beta cell failure is making some kinds of highlight in this lean diabetic population, and it is one of the point which needs critical dissection, how this beta cell functional dysfunction actually happened in the lean diabetic population as compared to the obese diabetic. Some predictors are there which may be the plausible explanation of this kind of beta cell failure, and also I covered those kind of predictors in the next few slides. So you can better understand how this kind of rapid beta cell failure is prevalent in the lean diabetic population. And higher prevalence and early initiation of the insulin use. That is also an important characteristics of the lean diabetes. They need insulin in the early stage as compared to the obese diabetic population. And also they depends or the other kind of therapy, like different monotherapy or the combination therapy with the available anti-diabetic drugs, or some kinds of modification in the lifestyle changes with some kinds of physical activity or some kinds of dietary factors. In spite all these kind of intervention available for the diabetes population, but in spite of this kind of alternative intervention schedule, they need insulin. So it is almost pointing out to the fact that they have severe beta cell dysfunction from their early onset. Because if we consider the different stages of the conventional type 2 diabetes in the obese population, in the classical criteria, we can classify them into different 5 stages from the onset to the progression, and sometimes they actually there is a exhausted beta cell condition or the beta cell volume in the conventional type 2 diabetes, but that needs a specific time frame for to happen this kind of beta cell failure. But in case of the lean diabetes, the beta cell failure happened in the early stage of the diabetic, or early stage of the diabetes, or the early initial stage of the diabetes. And that's why this kind of diabetic drugs, anti-diabetic drugs, like sulfonylureas or the glibenclamide or some kind of metformin, all these, they are not as a good corrective measure, because they need the existing or some kinds of minimum beta cell mass to act or to execute their function. But as the lean diabetics, they have the minimum or the exhausted beta cell function or the dysfunctional beta cell they have. That's why this kind of combination therapy or monotherapy are mostly they are not as a functional alternative of the anti-diabetic drug for this kind of lean diabetic population. But some specific drugs, they are capable to execute or capable to correct or to maintain the glycemic control if they are used in very early condition, when almost the beta cell mass are there to execute their function. So this is one of the important features of the lean diabetic, that that should be diagnosed early as possible. Otherwise, if there is some kinds of delay, and if that is progressed to different stage that make some kinds of minimum beta cell mass available for the action of the different anti-diabetic drugs or some other kind of traditional medicine or some other factors. So this is important, very much important, to make some kinds of diagnosis of the lean diabetic population at the early stage, when some beta cell mass are existing to work or to correct the glycemic control. Another feature, that is the lower TG, that is triglyceride, and the HDL ratio, because this TG HDL ratio is one of the indirect marker, because the triglyceride, higher triglyceride level, and the HDL level, they are considered as two different metabolic features of the conventional diabetes mellitus. So this is also very low. So that indicating the conventional pathophysiology of the type 2 diabetes mellitus. So they are totally different from the conventional or the obese type 2 diabetes. And very lower prevalence of the central obesity. But that is initially it was thought, but the recent data, the recent research articles, those are actually nullifying this possibility, the prevalence of the central obesity, because there are some data which are not significantly different from the diabetic population, obese diabetic population. But in the earlier studies, like 2015, 2014, or 2010, those research data on this population, the lean diabetic population, they just reported this kind of lower prevalence of the central obesity. But in the afterwards, or onwards the 2015, mostly the research data, they are indicating that this is not a changing factor or the changing characteristics among the obese population and the non-obese counterpart. And another thing that is important pathophysiological condition, the prevalence of microvascular complication. So microvascular complication is much prevalent in the lean diabetics as compared to the obese population, or the obese counterpart, obese diabetic population, because obese diabetic population, they have some kinds of morbid condition like hypertension, some cardiovascular ailments, or the myocardial infarction, stroke, and everything. This kind of macrovascular complication are more prevalent on the obese type 2 diabetes. But in the lean type 2 diabetes, the lean diabetes, basically, they have much higher prevalence of the microvascular complication. And different reports, they make some kinds of gradation in the occurrence of this kind of microvascular complication. The much reported complication is the peripheral neuropathy, then the retinopathy, and the nephropathy. So the key defect responsible for the lean diabetics is the hyperglycemia, as indicated by the impaired pancreatic insulin secretion. And these are the possible predictors for the lean diabetes. Just from the different reports, we can make some kinds of summary of this kind of these predictors, which may have some important contribution in the occurrence of the lean diabetes, but they need some detailed exploration, or the detailed critical dissection to make some statistical to establish some statistical connection with these kind of predictors. But as per the different reports which are available on the lean diabetic population, these are the important predictors which are plausible explanation for this kind of different pathophysiology of the lean diabetic population as compared to the obese diabetic population. Like genetic factors are there, polymorphism of the specific ATP sensitive potassium channel, or some kinds of islet cell proliferative genes, the gene specific to the islet cell, like FOXO, or some kinds of RPA1. These kind of genetic factors are responsible, or may be responsible, may have some direct association with this kind of beta cell dysfunction. As I mentioned, that in the lean diabetic population, beta cell dysfunction rather than the beta cell structural abnormalities are more prevalent in the lean diabetics. So there may be some kinds of polymorphism of the different genes associated with the insulin secretion, associated with the beta cell proliferation, or responsible for maintenance of the beta cell mass. Those are found to be defective in this lean diabetic population, and there is a higher prevalence of the polymorphism and genetic defect in the different gene array, or the different number of genes which are responsible to maintain the islet cell function, their islet cell structure, and also their insulin secretory pattern. Fat deposition, it is also very important, because mostly this kind of lean diabetic population, they have ectopic fat deposition. If we consider the fat deposition pattern in the obese diabetic population, they are basically the adiposity or the obesity, but they have low subcutaneous fat, the lean diabetic population, as compared to the obese diabetic population. But they have ectopic fat deposition, like the excess fat deposition in the liver, which is responsible for the hepatic insulin resistance, excess fat deposition in the pancreas, the fatty pancreas, or the fatty liver. These two important criteria, or the two important characteristics, are very much intuitive in the lean diabetic population of the lean diabetics. They have higher prevalence of the that actually magnetic resonance study revealed that higher prevalence of the hepatic fat and the higher prevalence of the pancreatic fat. So that indicate the ectopic fat deposition in this kind of lean population, the lean diabetics. Hypercholesterolemia also associated with the lean diabetic population, and the gestational diabetes and giving birth to a macrosomic infant. Macrosomic infant is a criteria, is when the childbirth and having the birth weight more than 9 pounds, or it is almost 4 kg, and that is called the macrosomic infant. So those population, those individuals, either they have or they develop some kinds of gestational diabetes, or giving birth to a macrosomic infant having the body weight or the birth weight of more than 9 pounds of the 4 kg. they are highly susceptible to develop lean diabetes in the future, in the course. So this population needs some kinds of surveillance, critical surveillance regularly, or regular checkup to diagnose the initiation of the any kind of hyperglycemia or any kind of diabetes in this population. So this is one of the important predictor for the lean diabetes development in terms of the female, those have the gestational diabetes and giving birth to a macrosomic infant. But one important criteria to note, important criteria to mention, that among the lean diabetes population, the prevalence is much higher for the men as compared to the female. But the proportion is almost 60-40 or 45, 35-65, like that. But among the female population, the prevalence of the gestational diabetes and some kinds of childbirth having that kind of macrosomic infant, those are most susceptible to the lean diabetes development. But now the rest of the two factors, that is poor in utero nutrition during the fetal development and lifestyle changes in terms of the smoking, alcohol consumption, and the dietary habits, these two important factors are considered as the most crucial contributor in the development of the lean diabetes. So most of the diabetic population, either they have poor in utero malnutrition, like they have some kinds of thin or fat change phenotype, like they have some kinds of less subcutaneous fat and less lean body mass. That's why they are like susceptible to this kind of metabolic perturbation or the metabolic disturbances. So these two factors, that is the poor in utero nutrition or malnutrition during the fetal development, because this kind of nutritional aspect is responsible for reprogramming the pancreatic development, or they are responsible for reprogramming of the pancreatic development, I'll say development during the organogenesis, and that are make some kinds of foundation for the metabolic platform of that particular individual, which may lead to some different kind of phenotype during their adulthood or during the course of life. And that's why this poor in utero nutrition is one of the major contributors as per the different reports published on the lean diabetes. And these criteria are more prevalent in considering, if we consider the Indian scenario, where the maximum prevalence of this poor in utero nutrition during the fetal development. And second one is the lifestyle changes, that is smoking, alcohol consumption, and the dietary habits. As I mentioned, that mostly this lean diabetic population, they are highly associated with the smoking status, because smoking is very much known for the leanness of the individual. So most of the smokers are basically, they have some kinds of lean phenotype, as the different components, particularly if we consider the nicotine, they are responsible for some kinds of, or they have some kinds of anti-inflammatory aspect of nicotine, depending on their binding capacity with the different nicotine receptors. If it binds with some kinds of alpha-7 receptors, they make some kinds of titer for the anti-inflammatory cytokines, and if they binds with the different alpha-2 beta-3 or alpha-2 beta-4 receptors, they make some kinds of other phenotype, like, or other condition, or the other microenvironment for the cytokine, like they make some kinds of pro-inflammatory cytokine. But in general, the smoker population, they have lean body weight, or the lean type, they are basically. But this smoking is considered to be one of the important contributor in the development of lean diabetes, because smoking are highly associated as per the different epidemiologic data or the different cross-sectional study. The smoking is one of the important post hoc factor predictor which are responsible, or which have some kinds of higher prevalence in the lean diabetic population as compared to their obese diabetic population. And there is one study which explored some kinds of changes in the in utero malnutrition, how this kind of in utero malnutrition reprogram the pancreatic development and how they are responsible for some kinds of generation of the different phenotype in terms of the obese diabetic population or in terms of the lean diabetic population. And particularly there are some kinds of epigenetic changes, so they make some kinds of genetic predisposition to that particular population of the lean diabetics, and they alter the metabolic reprogramming of that individual and how they react or how they make some kinds of response to the different dietary factors, different dietary habits, the different environmental condition, and the different lifestyle changes that is actually reprogrammed during their development, during the organogenesis or during pancreatic development, and whatever the template that is actually fixed during the pancreatic development, that is responsible for their particular phenotype during the rest of the part of the life or during the course of the life. And there are different factors that the genes responsible for some kinds of methylation and the modifications. All these are related with the islet cell proliferation, islet cell maintenance, and the insulin secretion, and some kinds of changes in the gene expression, which are very much associated with the maintenance of the glycemic control, like GLUT4, that those are responsible for the glucose uptake by the cell, PDX1, FOX21, IGF1, all these genes specifically, they are associated with the maintenance of the beta cell mass in the pancreas, or also they are responsible for the normal insulin secretory pattern in response to glycemic load or the metabolic load. So this kind of discrepancy in the metabolic reprogramming makes the individual more susceptible to the development of the lean diabetes mellitus, because those individuals which are basically malnutrited during their development, they have some kinds of different metabolic capacity and different metabolic load. And in this respect, one very known hypothesis, that is tryptogen hypothesis. So basically this tryptogen hypothesis is basically responsible for some kinds of generation or the accumulation of the fat when there is a prevalence of the diets or the prevalence of the energy, and those fats are basically utilized during the famine condition. So this tryptogen hypothesis, in one point, they are considered as a considering factor predictor for the type 2 diabetes of lean diabetes development. But the recent data or the recent research, they actually nullified those tryptogen hypothesis. But this kind of fetal reprogramming is almost validated now till now regarding the important predictor for the lean diabetes development. And the proposed mechanism for the maternal low protein associated with lean diabetes mellitus. So basically, as I mentioned, that the ultimate glycemic control in any individual is actually decided by the combination or the conjunction of the metabolic capacity of that individual and the metabolic load of that individual. So mostly these individuals who are in malnutrition, in utero malnutrition, they have limited metabolic capacity according to their metabolic factors or the responsible the different factors, physiological factors responsible to maintain the metabolic load. But they have excess metabolic load in the excess energy consumption, due to the excess energy consumption. So there is a discrepancy in between the metabolic capacity of that individual, which are actually reprogrammed during their fetal development, and the metabolic load they expose to the different metabolic load during their lifetime, during their course of life. So because of this kind of discrepancy, because of this kind of discordance in the metabolic capacity of that individual and the metabolic load of that individual, that makes them to develop that kind of particular heterogeneous entity of that lean diabetic or the lean type 2 diabetes. And another factor that is, as you mentioned, that basically the smoking, which is a dangerous liaison for the lean diabetes, as considered as a dangerous liaison, because as I mentioned, the prevalence of the smokers are very much higher in the lean diabetic population. And also from our lab, we established that nicotine is responsible for perturbing the hyperglycemia or the insulin resistance. So these kind of factors, as our animal model study is basically very much coinciding or very much supporting this kind of data of the lean population, that smokers are very much susceptible to the development of the lean diabetes, and there's a plausible mechanism. This kind of smoking, the different contents of the smoking in different format, it may be some cigarette, maybe some nicotine patch, nicotine gum, whatever the alternative of the smoking, those are not at all the safe to use, because this kind of nicotine content, having the nicotine content in the different smoking amenities, those are similarly toxic, similarly dangerous for the development of the discordant hyperglycemia or some dysfunctional islet cell function. So basically this indicates that the higher prevalence of the smokers in the lean type 2 diabetes. So it is important to make note that the lifestyle changes is very much important for this kind of lean diabetic population, because they actually worsen the different pathophysiological condition of the lean diabetes. And also this smoking is an indicative contributor in the much higher beta cell loss in this diabetic population, because the different contents in the smoker, or the different contents in the smoking items, they are reported to make some kinds of damage in the beta cells, as our publication reported that nicotine is responsible to induce the apoptosis in the islet cells, which is mainly responsible for the islet cell damage in the diabetic population, and that may be simulated in the lean diabetic condition, that leads to ultimately much higher beta cell loss or the higher beta cell damage in the lean diabetic population. And some different aspects are there which needs to be actually explored, or which need to be dissected in the lean diabetic, because in the lean diabetic population there is a different pattern of the insulin secretion and the different aspect of the insulin sensitivity. Some level of insulin resistance are there, but that is very low, and that is deferred in the different ethnic population, and so severe beta cell dysfunction compared to these obese patients are prevalent in this kind of lean diabetic population. And also the lean diabetics has, if we consider the probability or their chance of chance of developing insulin resistance is much lower. In the other side, there is a huge odd, or a higher odd, for the decreased beta cell function. And also the altered pro-insulin and the insulin ratio, because nowadays we are much concentrating on the different parameters to actually make some kinds of idea, or make some kinds of facts, to make some kinds of database for the diabetic population. This pro-insulin and insulin ratio is one of the important indicator for the insulin signaling in those population in the lean diabetics. And the altered pro-insulin and insulin ratio, that is the ratio between the C-peptide and the insulin, that indicates some kinds of greater beta cell function in the lean patients. Another factor that is called the obesity paradox, because mostly this kind of lean diabetic population, they are normal BMI or the lower BMI as compared to the obese. So there is a obesity paradox is there in the lean diabetic population, but this needs to be authenticated by some other detailed study, or some study with some much higher population, because very few studies they reported this kind of presence of obesity paradox in the diabetic population, lean type 2 diabetic population. But that needs to be validated with some larger data, or with some larger individuals who have this kind of lean diabetes. But the initial reports on the lean diabetic population, they pointed out this kind of paradox, the presence of the paradox in the lean diabetic population, although they are maintaining a phenotype of lower lean body mass but higher abdominal fat. they are susceptible, and the mortality rate is much higher in the lean diabetic population as compared to obese diabetic population. So this is all, and you can find that all-cause mortality was much lower in the high BMI and good aerobic fitness as compared to the lower or normal BMI with poor fitness. So we can make some kinds of clarification of this kind of presence of the obesity paradox because of the this kind of aerobic fitness, different aerobic fitness. So only the simplistic classification of the BMI to make some kinds of obese or non-obese or the lean diabetes population is not is a good predictor for to make some kinds of pathophysiological criteria or some kinds of pathophysiological scenario window for the lean diabetic population. But they need some kinds of other confounding factors, their lifestyle, their dietary factors, their reprogramming during the malnutrition, if they have that kind of different phenotype from the normal individual or the normal BMI, the lower BMI. So those confounding factors, they need to be considered, they need to be included when we classify this lean diabetes and the obese diabetes. So lean diabetic population, they have heterogeneous contributors, they have heterogeneous physiological predictors are there to make a very heterogeneous condition which are prevailing in the lean diabetes, and that makes some kinds of difficulty in scheduling the different intervention which are available. So that's why the sufficiency of that already I mentioned that simplistic classification of diabetes is in concern or in question whether that kind of classification be viable or not, be feasible or not, or can be validated or not. But they need some kinds of inclusion or the consideration of the different other factors which are basically making the different pathophysiology of this lean diabetic population of the lean diabetics. And if we consider the glycemic control in the lean patients, different drugs, those are effective to some extent. Like those are the available drug, anti-diabetic drug, sulfonylureas or the thiazolidinediones or metformin or like all other drugs. But sufficient beta cell function need to be preserved. Only then this drug can be effective. As I mentioned, that the lean diabetic population, they are characterized with very severe beta cell dysfunction, and that beta cell dysfunction is mostly contributed by the change in the beta cell volume and the damage in the beta cell. So that's why they need insulin therapy in the earlier stage. So this kind of drug or the intervention schedule only be effective when the sufficient beta function is existing, and that cannot be suitable for long term. If that progressed into severe condition, when the beta cell mass is maximally exhausted, then this kind of therapy will not be effective option for this kind of lean patients. And also the thiazolidinediones, which are very much effective in considering the beta cell dysfunction. That also shows some kinds of promise in treating this kind of lean diabetic population. But as I mentioned, as I underscored, the effective beta cell mass needs to be present or needs to be there for the activity or for the effect of this kind of available drugs. So this kind of treatment option mostly pointing out to the fact that these lean diabetic population, they need other kind of therapy. So like initially our director sir just pointed out that the physical activity, yoga. So this type of the traditional medicines, those need to be included in addition to these available anti-diabetic drugs for the possible intervention of the lean diabetics, because in most of the lean diabetic population, they are diagnosed at in a particular time point or the particular time frame when already they have exhausted the maximal beta cell volume or maximal beta cell function. So this kind of drug is not a good effective strategy or the good effective option for this kind of lean diabetics. So they need this kind of other alternative therapies available for the diabetes and infusion of this therapy. And another important point is further weight loss is recommended, because weight loss recommendation is most or the much prevalent in the obese diabetic population. But in case of the lean diabetic population, that can further worsen the pathophysiological condition of the lean diabetics. So conventional weight loss programming or the weight loss therapeutic schedule for the lean diabetic population is not effective one, because such recommendation is making more worsening of the condition, or more worsening of the lean diabetic population pathophysiology, because additional weight loss may interfere with the bone health, or the skeletal bone, musculoskeletal health, and the bone health, and the decrease further the lean body mass, leading to the sarcopenic obesity, and that can contribute in the that obesity paradox that prevalent in the lean diabetic population. And also failing beta cell cannot even cope with the small amount of insulin resistance in the lean diabetic population. So we cannot achieve that much of glycemic control in the lean diabetic population with this kind of recommendation for the weight loss in the lean diabetic population. And these are the challenges for the treating of the lean diabetic population. As I mentioned already discussed, that that combination therapy is required because the individual metformin or sulfonylureas or thiazolidine individually, they are not as much as effective as compared to that obese diabetic population. And also it is mentioned that this combination treatment only will be effective in the early stage of the treatment, or the early stage of the lean diabetics condition, or the lean diabetic population. Because if it is progressed to in the severe condition, when there is no available beta cell mass to anticipate these drugs in the system, then this combination therapy or the combination treatment is also will be ineffective. And simultaneously, from the initial phase of the lean diabetic population, it is important to start combination therapy, because individual therapy may not be as effective as with the combination therapy. And if any individual having the monotherapy or in therapy with one drug, that also can transform into a severe condition, that will not be a good option to achieve the glycemic goal, and rather that will not be effective at all to make or to preserve the beta cell or normal glycemic state or the normal glycemia in this population. And also optimized combination therapy early while significant beta cell function still remains. So I repeatedly pointing out to the fact that all this therapy will only be effective, all this therapy with this kind of anti-diabetic drug, if there still some beta cell mass remains. Otherwise, they will not anticipate at all with this kind of anti-diabetic drug. So we need we are in search for the alternative therapies of the available in terms of traditional medicine or in terms of the physical activity. And I request Director Sir to suggest to the ministry to include the yoga and the physical activity in the different society, in the different institute, in the different colleges, mandatory. It makes mandatory for the students as well, for the faculty as well for the all the individuals, because this can only be an effective one to counteract such condition where this kind of synthetic drugs are not will be a viable option or the viable strategy to counteract this kind of problems. And in the last slide, that the highlights are some lean diabetic population is a distinct clinical entity, as I covered all these points, which are evident from the physiological heterogeneity, and also the clinical presentation in terms of their the different criteria, the predictors and the profiles, like some molecular profiles and the biochemical profiles are quite different from the obese counterpart. And already I mentioned that lean diabetics are characterized by more pronounced beta cell failure, which occurs very earlier at the very initial stage as compared to the obese population, and that needs a very severe concern for the lean diabetic population to achieve the required glycemic goal. more aggressive treatment may be required. May be required means mandatory be required to achieve the that glycemic goal, to control the glycemic condition or the hyperglycemia in the diabetic population, lean diabetic population, considering also the occurrence of the hypoglycemia in this population, because the chances of hypoglycemia also very higher in the lean diabetic population, considering their different metabolic aspect of the metabolic load. So this kind of consideration is required to make to anticipate this kind of challenge of the lean diabetic population in the societies. And we are grateful to all the contributors. We are working on the different aspect of the diabetic mellitus. Thank you for listening. And thank you all the faculty members of the MDNIY, our director sir, Dr. Vandana madam, Dr. Rameshwar Pal sir, and all the participants in this webinar. My heartfelt thanks and gratitude to them for listening my lecture. Thank you, sir.
Thank you so much, sir, for this wonderful lecture.
Welcome.
Sir, there are so many questions in our comment section. I would like to take few of them.
Yes.
सर जैसे कि आपको पता है कि आजकल बच्चों में डायबिटीज के बहुत से केसेस देखने में आते हैं, तो अगर परसेंटेज के हिसाब से देखें तो बच्चों में लीन डायबिटीज का कितना प्रतिशत पाया जाता है?
बच्चों में लीन डायबिटिक्स, because we are now facing the problem of double burden of malnutrition. Double burden of malnutrition means they are anthropometrically they are non-obese, but metabolically they are obese. So in considering this kind of double burden of malnutrition, the prevalence of diabetes among the children are much higher. And considering these facts, the government of India has initiated some kinds of research to explore this kind of dietary factors, the dietary criteria, and the other interventional criteria to cope up with this kind of much higher prevalence among the development of the diabetes among the children, or to cope up with the double burden of malnutrition. So considering 5 or 10 years later, the proportion of the diabetes is much higher among the children because of this kind of in utero malnutrition. And also, as I mentioned during my lecture, that this kind of phenotype, these kind of children who have this kind of double burden of malnutrition, they have separate metabolic capacity they have, and they are exposing during their childhood with different kind of dietary factors, dietary habits in the different ethnicity, in the much junk foods or the different kind of food pattern, the dietary habits, and that's why there's a huge excess energy available to them, and that actually perturbing or the responsible for the perturbation of the metabolic load in them. So in terms of their anticipated or compromised metabolic access or the metabolic capacity, they are exposing to the higher metabolic load. That is basically responsible for this kind of excess prevalence among the this kind of prevalence of the diabetes among the children nowadays.
सर लाइफस्टाइल संबंधी चेंजेस करने से डायबिटीज, लीन डायबिटीज मेलिटस जो है उस पे रोकथाम लगाई जा सकती है, तो लाइफस्टाइल में क्या-क्या चेंजेस लाने चाहिए जिससे लीन डायबिटीज मेलिटस ना हो?
As I mentioned and requested our directors to induce this kind of yoga program in the different society, because as the lean diabetic population, they have higher beta cell dysfunction. So this kind of synthetic drugs is not a better option to initiate, and mostly as per the IDF Atlas 2021, that more than 40% population who have diabetes, but they are unaware totally. They are undiagnosed diabetes. So mostly these lean diabetics, as they are non-obese. So in a conventional term, they are not very much aware about the metabolic programming or the metabolic dysfunction in them. That's why they are not intended to go to the doctors or the clinicians for some kinds of diagnosis. So this kind of diabetic population or the lean diabetes, they need some kinds of physical activity. They need some kinds of different dietary factors as the conventional diabetics, and also they need some lifestyle changes in terms of the smoking and alcoholism. As I mentioned, that smoking is one of the a major contributor in development of the lean diabetes, as per the reported research, because smoking is responsible for some kinds of making some pro-inflammatory condition in the individuals, and simultaneously they are responsible for more beta cell damage. So this smoking, the alcoholism, this kind of lifestyle changes very much important, very much needs to be in consideration to make the intervention schedule or the intervention strategy for this lean diabetes.
Thank you so much, sir, for delivering such a wonderful lecture to our audience.
Yeah,
thank you for accepting our invitation, and I would like to thank you from my own behalf and behalf of our MDNIY family. Thank you so much.
Myself, I'm also thankful very much to you, Rameshwar sir, and our director sir, for giving me an opportunity to present this kind of topic among the audiences, and also the different faculty members in your well-esteemed institute. And thankful to you again, and also to the director sir for giving me opportunity.
I would also like to thank Director of Mukherjee Desai National Institute of Yoga, Dr. Ishwar Basavaraddi sir, for taking out time and joining us today. Thank you so much, sir. And I would also like to thank Communication and Documentation Officer of MDNIY, Mohammad Tayyab Alam sir, for his help and support in organizing this webinar. And thanks to our technical team, and thank you to all the viewers who have joined us today. Thank you so much. And now, as per the tradition of our institute, let us end the program with Shanti Path. Om Sarve Bhavantu Sukhinah, Sarve Santu Niramaya, Sarve Bhadrani Pashyantu, Ma Kaschit Dukh bhag bhave, ma kaschit dukh bhag bhave. Om Shanti, Shanti, Shanti. Thank you so much, sir. Thank you.
Thank you, sir. Thank you, director sir, for your kind presence.
Thank you, Sandip ji. Thank you, Vandana. Thank you all.
Thank you, sir. Thank you.